about the 6 T's of spinal MIS. Can we turn the lights down? I think somebody. So these are my disclosures. So let's talk about MIS. I think it's probably not a bad idea in the beginning of a 3-day course to kind of go through a definition. I had the honor to be part of a task force within AO Spine that worked over the last 3 years to put together a curriculum for minimally invasive spinal surgery. And one of the first things that we were trying to do is we're trying to find a definition. And it was mainly by consensus, based on literature, based on experience. But we settled on an MIS as a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function, striving for better outcomes than traditional techniques. So you can see here, it's certainly technology-dependent, and the goal is really to have the same or better outcomes than what we usually see with open surgery. And there's no Class 1 evidence yet that we're there. There are certain procedures, I think, that have proven over the years to be extremely successful. But obviously, the goal is to really expand that and make sure that everything that we do in MIS has some kind of scientific basis and also a superior outcome in our patients. Now, the rationale is really to avoid soft tissue injury. So we avoid, it's really related to the access, MIS surgery. Once we're there at the target, we do pretty much the same thing that we would do with open surgery, but we're trying to minimize the access injury and pathology to the muscle, the tendons, the bone, and so forth. Now, if you look at the evolution of MIS surgery over the years, if you look at indications for surgery and you go from simple surgeries and easy pathology like a lumbar disc herniation, then stenosis becomes a little bit more complex, the treatment. Then pathologies that require 1, 2, 3, 4 level fusion. And the most complex surgeries are probably significant deformity surgeries. There are obviously open traditional ways of treating those problems, and most of those have been translated more or less successfully into minimally invasive solutions. And that is tubular discectomy or endoscopic discectomy for lumbar disc herniation. And then, the workhorse within MIS certainly is the tubular decompression, the MIS TLIF, the lateral surgery, and then combination of those for more significant deformity surgeries. And again, the idea is, and really that has been translated in every anatomy in the spine. The idea is, small incision, less damage, lower complication rate, less bleeding, less infection rate, earlier return to function, and so forth. And if you look at the benefit zone, and I really like this slide because it kind of really puts everything into perspective. If you look at easy pathology to complex pathology, you look at the complexity of your pathology and the surgery, and then you look at the level of invasiveness. And invasiveness can be measured, blood loss, infection rate, length of surgery, and so forth. There are many different parameters. But you'll see with open traditional surgery, I think it's fair to say that easy pathology is really low complex with open surgery as well, and it's a low risk and very successfully treated. But then when you come to more complex pathology, the curve goes up very quickly, and it gets fairly complex very early. Now, the whole idea with MIS surgery is to dampen that curve. And where exactly that curve is changes from year to year, month to month. But the idea is really to and the MIS benefit zone is really kind of like in between here. I think, and that's the first topic of discussion. We've got some world experts in endoscopic surgery here, but I would challenge that if you have a lumbar disc herniation, whether you treat it with open surgery, with a tube, with an endoscope, it's probably not a huge difference. But then once it comes to more complex pathologies, and those are patients who have lumbar spinal stenosis, 1, 2, 3, 4 level stenosis patients, spondylolisthesis, maybe spinal instability, patients who need a 1-level fusion. And I would say maybe up to 3, 4, 5 level fusion patients. Those are the patients I think who really benefit from MIS surgery. And I think we have a lot of data really showing that in terms of blood loss, infection rate, lower revision rates, and so forth. So I would think that between lumbar stenosis and like 3, 4, 5 level fusion surgery, that's kind of like the benefit zone for MIS. Once we get to the real complex deformities, we lose the benefit of MIS. Too many incisions, too many different technologies, too many different approaches. It becomes so cumbersome that it's just easier and maybe more effective to do it with open surgery. But that doesn't mean that maybe part of it you'll do MIS. Maybe you'll do the lateral approach MIS, and the posterior approach you do maybe open with osteotomies and so forth. Well, putting that all together then, what determines the success of MIS surgery? One thing that we never talk about, we talk about technology a lot, but we never talk about patient selection. I always tell the fellows and the residents, the least invasive operation is the one that you don't do because the patient doesn't need it. And we see that all the time. Patients come to the office, they had an MIS operation, and you're wondering, what the hell, why did that patient need surgery in the first place? So I think that's really, and that's target or patient selection, procedure selection. We just don't talk about that enough. And I would love to put on a course, or a half-day course, where we just talk about how to examine a patient and how to derive at a surgical decision. And that would be, I think, really worthwhile, but probably nobody would show up, but it would be interesting. So tools and technology, we talk about that a lot. And the majority of the course is probably going to be about tools, technology, and techniques. So that includes navigation, instruments, expandable cages, and so forth. Techniques, and the techniques, if you do a lot of MIS surgery, you'll realize there are certain things that come up over and over again. And they're really, in terms of the surgical technique, we'll talk about that a little bit more. It's the fact that you can do a unilateral approach for bilateral decompression. That comes up. You can do that with open surgery too. But you can do it exceptionally nicely with tubular surgery and also with endoscopic surgery. So the idea that you don't have to open both sides. You go in from one side, you go over the top, you do bilateral decompression. That's an MIS principle that comes up all the time. Then together with that comes the fact that by doing that, you preserve stability, and that means that you do less fusion surgery. You can do a decompression, and you don't have to do a fusion frequently because patients don't develop instability based on the surgical approach. And then finally, interbody fusion, and there are two surgical ideas associated with that. One is indirect decompression, and the other one is deformity correction. Finally, every surgeon, whether you're teaching or you're training yourself or you're teaching somebody else, teaching and training is certainly part of our learning curve, and is part of how we become better surgeons. Testing or research, we're not going to talk a lot about that. And then talent, the question is, is that innate or is that something that we can train? I'm a firm believer that talent to a large extent, just in sports, we know that from coaching and so forth, you can teach talent to a certain extent. And I think we have to really maximize that. That's our obligation. If we train residents and fellows, we've got to make sure that we give them the best opportunity to really take advantage of their abilities and develop talent and skills. So this is just an example in terms of target. There's a patient who came a few years ago. She had a lumbar. She came to me essentially with neurogenic claudication. She had leg pain when she walked, not a lot of back pain, and she had this surgery done a year before. And she had. I was looking for the incisions. I couldn't even see the incisions. I mean, she had two tiny incisions in her back, and the X-rays look fine. She had good fusion. It was beautifully done surgery. So extraforaminal, 2 cages in percutaneously. And then we got the MRI scan because she still had the same symptoms that she had before surgery. And she had, lumbar spinal stenosis, not only at that level, but now also at the level above, probably because as an adjacent level phenomenon, maybe, I don't know. But she had essentially neurogenic claudication. And I felt that there's a perfect example of an MIS operation that was done perfectly well, but I think for the wrong reasons. So we did a tubular decompression, and she did very well. So that's just an example of how MIS can be done, but you really got to do the right procedure for the right problem, and I think we should talk much more about that. Tools and technology. So that's the microscope is a key element of MIS surgery, of course. Now more and more the exoscope. I don't know here who's used the exoscope. It's very exciting technology. The endoscope. Navigation, expandable cages, all these things are exciting. We talk about that a lot. We can look at it downstairs with the vendors in the exhibit hall. No lasers, I'm sorry. We have a laser on the X-ray machine. So when we get an X-ray, so I can always tell patients, yes, we use the laser. but for different purpose, but it's still laser-related surgery. So, so the three techniques, the technique principles is contralateral decompression, minimize instability, and then interbody fusion, and then navigation maybe. So you can do a bilateral decompression through a unilateral approach. And the idea here is, again, instead of doing this big old incision, a fair amount of blood loss, and you remove the posterior elements, you remove the bone, you got a beautiful decompression, but it's probably not necessary because you can get the same amount of decompression, and we can see that on Saturday in the lab. And some of you may still wonder how that is really possible, but I can guarantee you that you can get the same or better decompression with tubular surgery and probably with the endoscope as well. And that's, we'll go through this a bit later. So the idea is really to go contralateral. You tilt the table, you tilt the tube, and then you do the over-the-top decompression. There's a movie about that if you ever want to watch that. So, different movie, but same title. So, and then you minimize the instability because you're leaving all those elements that cause preserve stability. You leave those intact. So in patients with spondylolisthesis, you don't always have to do a fusion. You can sometimes just do a decompression, and those patients do really well. So, and we published that. We had one of our fellows do a review of the literature looking at MIS decompression in patients with spondylolisthesis and lumbar spinal stenosis, comparing open surgery versus MIS decompression. And the summary was here that the patient satisfaction and the delayed fusion rate, the patient satisfaction was much greater with MIS decompression, and the delayed fusion rate was lower in patients who had MIS decompression. And I think that really, certainly in our practice here, has become a standard way of treating these patients. So unless they have severe mechanical back pain or movement on flexion extension films, or there's any other reasons why we think they really need a fusion, we'll do a decompression, MIS decompression, and not necessarily a fusion. And I can tell you, on the Upper East Side in Manhattan, there's so many patients with spondylolisthesis and lumbar stenosis that we still do a lot of fusion surgery, simply because the population is such that every other patient I see has grade 1 spondy with lumbar stenosis. But if you can avoid fusion in 80% of those patients, I think you're doing well, and you can really save them a lot of surgery. So, and then that really expands then to the fact, once you're good at doing a decompression without with the tube or with the endoscope or with the tubular retractor or with the specular retractor, as they do in Europe frequently, I think you can really expand your indications of a decompression. So a lot of patients with spondylolisthesis, soft foraminal disc herniations, we go over the top. We can talk about that in the lab and during the rest of the course. Sometimes, we see patients who present with 2-level lumbar stenosis, L4-5, may be unstable because of spondylolisthesis, but then they have L3-4 stable stenosis. We may do a 1.5, we do a 1-level T-LIF, MIS T-LIF or X-LIF or L-LIF, and then do a tubular decompression at the level above. And then most synovial cysts will just decompress unless there's true, real, obvious instability. So that really cuts down on your fusion surgery, but also expands your ability to really offer patients, I think, a very reasonable surgical options. I think I'm gonna end here, and we're going to talk much more about a lot of these things over the course of the meeting. And thank you for your attention. Do we have 10 minutes now for discussion still, or?